Thank you. Good morning. I appreciate the opportunity to be here and to update you on Summit's Utrophin program. Summit is a 13-year-old company founded out of the University of Oxford and Kay Davies' lab, and we've been public for quite some time on the exchange in the UK. We've got a growing presence in Cambridge, Massachusetts, and earlier this year we also listed on NASDAQ, so it's important we show our disclaimers. Very importantly, and I thought important to put this up front, Summit has received considerable assistance and financial contributions from a range of organizations, and that's been really instrumental in bringing the program to where it is today. And we're very appreciative of that, and of course, as we come to the trials, of all the participation of the families in those trials. So we're working on Utrophin. I'm going to explain what Utrophin is and then take you through the pipeline. So Utrophin, our bodies maintain two very big, very similar genes, Dystrophin and Utrophin. No one actually knows why we have both, but we do. Utrophin was actually discovered by Kay Davies at the University of Oxford some 25 years ago, and now is Professor Dame Kay Davies, and we continue a very close relationship, and indeed a lot of our early development and discovery work continues with the folks in Kay's lab and Steve Davies' lab at the University of Oxford. I'm going to be showing you later some of the data that comes out of those labs. A little bit of background I think is important, specifically thinking about Utrophin and the relationship with dystrophin. So if you think of the muscle fiber as a trampoline, both dystrophin and Utrophin are the molecular shock absorbers of the system, where they bind the skeleton within the muscle fiber to the membrane, the outside world, and so all the muscle fibers that form a muscle all work together. And it is the dystrophin or the Utrophin that work to link the skeleton to the outside world at these very defined sites, which are relatively limited. And the idea here is if you've got DMD, those are unoccupied sites, and what we want to do is occupy those sites with Utrophin. So this cartoon I'm going to go through in some detail because it explains the thesis of what we're trying to do. So if you look at the top line, this is a normal fiber, and Utrophin has the function of being the molecular shock absorber that is expressed during repair of a muscle fiber. So in a repairing muscle fiber, it's not dystrophin that's the molecular shock absorber, it is Utrophin. And you can see that I'm following the top row. As the fiber matures, what happens is that the Utrophin gene is turned off, and the system, in a way that is still not really known, calls for dystrophin. And so by the time you get to a mature muscle fiber, you have exclusively dystrophin as the shock absorber and no Utrophin. Now let's look at what happens in a patient with Duchenne muscular dystrophy who is not making dystrophin. In an exact the same way, in the repairing muscle fiber, which there are a lot of, those muscle fibers are making Utrophin. Utrophin is entirely unaffected. It's a completely separate gene from dystrophin, and the repair process works, in fact, really well. Again, as that muscle fiber is maturing, what happens is the system is turning off the Utrophin and calling the dystrophin. It doesn't know that there's no dystrophin. So what happens is by the time you get to a mature fiber, you have no Utrophin, and because the gene for dystrophin is defective, you make no dystrophin. And so you end up with a fiber that has no molecular shock absorber, and as you've seen on many of the slides over the past few days, you get degeneration, and you go round and round this cycle, and with all of the other downstream effects, and gradually you get more and more infiltration, fibrosis, and fat, and so forth, and hence the decline in the disease. Our objective is very simple. We're developing small molecules which are designed to keep on the expression of the utrophin, which the system is perfectly able to make. And so to have a mature muscle fiber that, instead of having dystrophin as the molecular shock absorber, has utrophin. Since the discovery of utrophin by Kay, there's some 25 years of work by her and her lab and others around the world showing very elegant transgenic work and in vitro. I'm actually going to show you absolutely none of that data. I'm going to jump right to some clinical data. I'm going to come back and show you some early stage data with some of our later compounds. But I'm going to jump right to some clinical data with our lead compound. So our lead compound is called SMT C1100, another really cute name. And after our first healthy volunteer trial, we went into a trial of 12 patients to really check for safety, tolerability, and pharmacokinetics. Are we seeing the exposure that we need in order to have efficacy in these patients? I should mention that there are some issues that makes SMT-C1100 a bit tough to work with. It is not a perfect molecule. It's very insoluble. It's metabolized very quickly. So we're having to give quite large doses, as you can see here. But it is oral, and we think what's crucial is to get what we're calling a first-in-class molecule progressing through the clinic and to a therapy, rather than wait for perfection. So we had some really good news from this trial and some more complicated news, and I'll go through first of all some good news. The first is it's been safe and well tolerated in all of the work so far, and in our very lengthy 3-species animal tox work. It's an extremely safe molecule, which is great. There was 100% compliance. There were no missed doses, so that was also good. In the category of drug development is not a linear process, we also have our little non-linear aspect here. We found that the level of drug that we're seeing in the plasma of the patients, most of the kids had a lower level of drug exposure than we were expecting. If you look at the graph, what you can see is the kids resembled the adult healthy volunteers who had been fasted. We'd done a study in the healthy volunteers, and we've shown a very strong effect of food. The drug needs food to be present, to be taken up effectively. And we'd shown that in the adults. We had designed this trial to be taken after food, but we'd not really specified the diet. And I think, obviously, in retrospect, that was a bit of a mistake. So most of the kids you can see look like are showing a drug exposure very similar to the fasted healthy adults, which is too low. However, interestingly, 2 of the patients out of the 6, so 1 out of 6 boys, did show very nice exposure. We went back and tried to learn more about this, and we believe that there was, because of some of the very low fat diets, and we need a balanced diet, not a high fat diet, that these kids were on. That's why we were seeing not good exposure. We also, we're testing a number of safety parameters, as you do in all of these tests, And even though most of the kids had low exposure, only a couple had high exposure, we also actually had a pleasant surprise. Here's the pleasant surprise, which was quite unexpected. These are markers that are traditionally thought of as liver damage markers, but they're also measures of muscle damage. And because the muscle is leaky, you get creatine kinase and some of these other enzymes leaking into the plasma. In this very short trial, even in the kids who had very low exposure, we were seeing a very rapid decline in creatine kinase. We know that that's not due to anything to do with the liver, because we have a measure of a true only liver enzyme here as a comparator, and you can see that is unchanged. So we were actually very surprised and very encouraged by this. So we have now gone back after a little bit of time, actually rather a lot of time, we've gone back into the clinic, and we are right now undertaking what we're calling a modified diet study. We've made this trial a little bit complicated for a couple of reasons that I'll go through. So here, every child and family is working with a nutritionist at their center to ensure they're on a balanced diet and that the drug is taken within 10 minutes of dosing. In addition, and just as a sort of belt and braces approach, they're also taking a glass of full-fat milk immediately following the drug. Something else that we're doing here, which is a little unusual for a trial of this design, is we're doing this as a placebo. Each child is going to have drug, but they will each be their own control. So if that drop in creatine kinase is due to a drug effect, we will see that. There is the possibility that drop is due to some a spurious reason because the child is on a trial, but if it's actually due to drug, because of the design of this trial, we will actually see that. This trial is fully enrolled, and we expect to be issuing the results before the end of September. Following success of this trial, our plans are to go very quickly into an open label phase 2, and then next year to start a randomized placebo-controlled trial. Both of these trials we plan to have sites in both EU and US. I'm going to turn to from SMT C1100 to the rest of the pipeline just for a moment. We continue to work very closely with the University of Oxford, and in fact, all the discovery, all the animal models, all of the in vitro assays are done by our colleagues at the University of Oxford, principally in Kay's lab, and I think that's actually a fantastic collaboration with probably the best center of excellence in Utrophin in the world. So I'm going to show 2 slides of data coming out of that lab, principally generated by Simon Giraud and colleagues at Kay's lab. So if you look at the panel on the left, these are MDX mice that have been dosed for 5 weeks, and then they take out a muscle and they say, how quickly does it weaken when you make the muscle exercise? If you give it 5 contractions, how much strength does it lose? And you can see that in the MDX untreated mouse, after that it loses about 50% of its strength. The sort of yellowy color, I'll call it mustard, the mustard color of a unaffected mouse loses about 10 to 15% of its strength. And after only 5 weeks of dosing, I'm sorry, I should have mentioned, this is with one of our second-generation compounds, the animal has recovered nearly half of its full function, which is really encouraging. So that's a measure of skeletal muscle function. If we look on the right, looking at the diaphragm, which is also a muscle, first of all, you can see that the diaphragm is making more utrophin. But importantly, down below, you see on the drug-treated, there are no red blobs. The red blobs, which is my technical term, are showing the infiltration of calcium. When the muscle membrane is damaged, one of the very first effects, and actually you've seen it on a number of slides, people showing you get a movement of calcium in, and from that you get a lot of the damage and the downstream problems. And what you can see is, with one of our second-generation compounds, very quickly, after 5 weeks of dosing, you have no calcium infiltration into the diaphragm. So that's really great. I'm going to show you one other piece of data from the Oxford lab with both a second generation and our clinical candidate, C1100. If you go back to my cartoon at the very beginning, remember what we were trying to do is see utrophin all the way along the fiber. Now, traditionally, people section muscles across the muscle, so you look just at the end. And we're now doing it the other way, to look along the length of the fiber. And what we're seeing here, and really this is the first time someone's done that, is we're seeing utrophin along the length of the fiber, as opposed to, if you like, in a dystrophic situation, you will see utrophin at the little areas where it is being repaired and coming and going, but we wanted to see it all the way along. And so that's really, really encouraging. And the bottom panel also shows you one of the proteins in the dystrophin protein complex, which sits in the membrane and connects one fiber to another. And it's crucial to restore that so you get function of the fiber and coordination of all your fibers. And you can see that both these molecules are doing that nicely. I'm going to show you one other piece of data, which is John Tinsley at Summit, together with Francesco Montoni, Caroline Suri, and colleagues at University College London. We've been developing novel biomarkers. And this is a really important biomarker, especially for the mechanism that we're interested in. So John and Francesco and colleagues have been developing automated way of taking a muscle section, staining it to show all of the muscle fibers, and then using a component of the cytoskeleton, which are myosins, which are only expressed during regeneration, and then using automated scanning and computer programs to count thousands of fibers rather than a person looking down a microscope. And what has been done here is to measure the number of regenerating fibers. And this is actually a Duchenne muscular dystrophy patient sample, not from our trial, because we've not been taking biopsies, but that they already had. And what you can see is there's about 40% of regenerating fibers. This is going to be a really important biomarker as we go forward, because if our thesis is correct and the utrophin, our drugs can make the utrophin that goes to the membrane and restores the complex, we should see in the people, as in fact we're seeing in the mice, we should see more mature muscle fibers after treatment and fewer regenerating fibers. So that's a really important assay, and we're excited that has worked out so well. So in summary, we're advancing a whole pipeline of compounds. We have our clinical candidate, C1100, that continues its progress in the clinic. We are also, because we recognize that we can yet improve the formulation and incorporate some of the food elements within the formulation itself, we're continuing that work, and in fact are going to put some novel formulations into the clinic later this year. We're working in collaboration with the group at University of Oxford, and I've shown you some of the great data on second-generation molecules, and we hope to choose one of those to be able to, in a way, as a fast follower and maybe a best-in-class, to put that into the clinic later next year. And very much earlier stage research going on at Oxford with novel screens and potentially novel mechanism of action compounds. Again, all focused on utrophin modulation as our core interest, and that work continues. So that summit and our pipeline, I'd like to thank you.